I know that in the community there are some concerns about the backlogs in the system post-COVID. So this question is, I'm fortunate that my blood tests suggest that my PSC is relatively inactive. Has monitoring of patients such as me changed in recent times due to the present pressures?
So, short answer to that is yes.
Right.
I think if you cannot turn on the news without seeing that there's long waiting times for people, waiting for hip operations, or it might be gallbladder removal or whatever it happens to be. But when the system's under pressure and new patient waiting times are long, then also follow-up waiting times will be long, because it's the same staff trying to manage both those things. So when you've got an increase in one aspect of the waiting list, it does have a knock-on effect on others as well. And this is something that has sort of vexed me as a clinician for a long time, is that the same degree of focus politically isn't put on follow-up waiting lists as it is to new patient waiting lists. The obsession is time to be seen first and having your treatment completed is the sort of the holy grail of healthcare provision. And yes, there is a focus in NHS England, Scotland, Wales, Northern Ireland on follow-up waiting lists, but there's not the same laser-eyed focus on it. It doesn't attract the same headlines. When was the last time you saw a headline on the BBC News saying delayed follow-ups? You don't see it.
No, you don't.
Yet actually, for many people who are under follow-up clinics, that can be more clinically significant than it can be waiting a year for have an ingrown toenail done, if you have a serious condition potentially like PSC. So I think it speaks to some of the challenges we have within our healthcare systems and what things are prioritized, and certainly the impact of the pandemic we've seen and the demands on front door care. So that's ED and MAU, they're full, the hospitals can't discharge people, and more resources having to be allocated to try and manage those problems. And that takes some time away from some other parts of the service, including elective care like endoscopy and outpatient. So there has been increases in waiting lists as a consequence of all these multiple impacts. The question is, what do we do about it, isn't it? And I think we have to sort of find better ways of delivering care. I mean, I think, many people will have had virtual appointments, and that might be one way of not speeding up care as such, but providing more efficient care, particularly if you travel large distances. Can we do more care for more people by doing remote monitoring? But I certainly think if you have experienced a delay in care, what I would advocate is don't be afraid to follow that up.
Yep.
In fact, I'd very much suggest that you do follow it up with applied inquiry. There's a number of different routes you can do that depending on what service you're in. Now, some services, like the transplant services, if you've had a transplant, there'll be transplant coordinators you can contact, and they are the conduits to everything. They're amazing, and they are there, and they will facilitate lots of different things. But some other services, my own and many others, will have a nurse advice service that you might be able to contact, and they can help navigate where you are. And it might just be that if you're feeling well, you may just need a blood test. It might be that your ultrasound is overdue. And actually, if that is the case, we can chase those things along without actually physically being seen in the clinic. So when I'm talking about new models of care, I think we can do more things with better communication between us as healthcare professionals and you as people suffering from PSC to try and facilitate that. Because if you're feeling well, you've got no active symptoms, sometimes actually, although we would like to see people face to face, until we catch up, if you're having your blood monitoring or having your ultrasound monitoring, then that will fulfill that major purpose. That's the main thing we need to be looking at. And so we can often fill in those gaps in care by doing some of those things more remotely for you. So if there are support services run by the nurses, whatever, contact them. If not, you can contact the consultant secretary, or you can ring into the hospital switchboard and say, I need to speak to the manager of this service, and I just need to know where things are happening. Where am I in terms of my appointment? I'm concerned I haven't had this done, which I normally have done. Can you please advise me? And then they can normally get hold of the medical team and hopefully get that issue resolved for you. Because a lot of these things can't be managed relatively remotely, and that will speed things up for you.
Great. And the next question actually is related. You might have, you've probably answered it, but are you seeing delays in your own clinic? And what's the best way for people who've got delays in test results? We've heard of, you know, some pretty horrible stories of people waiting months and months and months for test results. What's the best way that they can push for that? I think you've answered that, but is there anything else you could add to it?
So yes, I mean, my service is no different to anybody else's. We've all been badly affected by some of these impacts, and I think, but there are things that we are doing to try and mitigate that. We're not just going, oh well, we'll wait a couple of years until we catch up. You know,
that is really good to hear.
so the things that we are doing locally, and I'm sure, and because in my IQLS role, of course, I look at what other services are doing across the country, so I get to see some real examples of excellence in the way people are tackling these challenges. And you know, I can't say that every single service in the country is doing this, but what I can say is I've seen really inspiring examples of people services really pulling out all the stops to try and find innovative, creative ways and working extremely hard to try and manage that. So people are working on it. I think that's important that people are aware of that. What are the simple things that can be done to try and improve this? From a clinician perspective, we do a number of different things. One is, and not just related to people with PSC, we look at all our waiting lists, and then what we do is we validate them. You'd be surprised how many people get referred to a service because of a given symptom, and then by the time actually you come to call for them, the symptom's gone away, and then they don't bother to respond, and then don't bother to come. So sometimes for certain things, you can clerically validate it by just rewriting people saying, are your problems still there? If so, that's fine, we'll keep you on the list. But actually a lot of people respond and go, actually, no, I haven't got PSC. I just had a bit of tummy ache. It's all gone away now, and my GP's happy. So that frees up capacity for other people. Similarly, we do that for our follow-ups then, looking at, so we do follow-up validation clinics. So instead of seeing 10, 12 people in a face-to-face clinic where it takes a lot more time, we just go through large numbers of records and just say, oh, so-and-so is overdue. Okay, and then we can write to them and say, right, okay, we haven't got a face-to-face appointment for you at the moment. Contact us if this happens, but in the meantime, I'm going to organise your bloods, I'm going to organise your scans, and we'll catch it all up that way. The third thing we're doing then is we're looking at whether our clinics work in the right way. So at the moment, we used to have very sort of generic clinics, a bit of everything in them, and we're starting to cohort clinics. So we've got a liver transplant clinic, a complex liver failure clinic, and then we've got an autoimmune clinic that's going to be set up. So because you've got a dedicated clinic, then it's a bit easier to manage that clinic because you know what the risk is in that clinic, and you say these are the patients that you know, absolute last resort should be deferred appointments, and we need to prioritize this group of patients because we know they're higher risk or lesser risk. So that's one of the other ways that we're looking at trying to get the waiting times down so we can get people in when they need to be. And as I say, we have a nurse advice line then, which is another conduit that people can contact us if they've got concerns, because actually you might be fine and something might develop unexpectedly. You might be getting more cholangitis than before, and we need to know about that. So it's about developing that two-way communication between us as clinicians and healthcare professionals and yourselves as the people who are having to experience liver disease. And so we'd really need to encourage that two-way communication to make it a real partnership rather than us sitting in a clinic just saying, you know, you'll come when you're called.